My name is Amrita. I'm a medical student. What is your name?
I'm Shabuddin Sarkar.
How old are you?
I'm 24.
So I'll be examining your chest and lung today. So for that, you need to take off your t-shirt. Is it fine with you?
Okay, sure.
Okay, so then we may proceed for the examination.
We note the shape of the chest and see if there are any bony deformities and asymmetry. We observe the sound of breathing to clarify if the patient has any breathing distress. We listen and count the number of breaths per minute. Normally, an adult breathes 14 to 20 times per minute. We inspect the patient's neck for any retraction of accessory muscles. Normally, it isn't present. We proceed with the palpation of the sternal notch to check the position of the trachea. It should be in the midline. We check the color of the nail of the patient, which will be pink normally. In case of nail bed cyanosis, it appears bluish. We begin with inspecting the chest for contour, symmetry, and deformities. We also inspect the overlying skin and palpate the chest wall to locate the area of pain or tenderness. To test chest expansion, we place the thumb across the patient's spine at the level of 10th rib and spread the fingers slightly across the thorax. We ask the patient to inhale and exhale deeply while we watch the divergence of the thumb. Normally it's 2 cm and we feel the range of symmetry. While palpating for tactile firmities, we ask the patient to say 99 repeatedly. As the patient does so, we feel the vibrations of tactile firmities. We start percussion of chest in a systemic manner, moving down the thorax and side to side. This is called the ladder-like pattern. By this, we identify and locate the area and quality of any abnormal percussion note. We ask the patient to breathe out and identify the lower level of the diaphragm, and then ask the patient to inhale and measure the descent of the diaphragm or the diaphragmatic excursion. Auscultation is the most important examination technique for assessing airflow. We will listen to the expiratory and inspiratory sound side by side to differentiate if there is any. Having the patient lie down in supine position, observe the condition of skin and inspect the chest for any deformity and asymmetry. We palpate the chest to locate any area of pain and tenderness. Now assess the chest expansion by placing the thumb along each costal margin with hands along lateral ribcage. As patient breathes deeply, we observe how far the thumb diverges and feel the symmetry and extent of respiration. Now we proceed with the palpation for the tactile firmities, following by the percussion of the anterior and the lateral chest. We listen to the
Say
transmitted
99 for me.
voice sound as the
99,
patient says 99
99,
and E and
99,
also feel the
Say E.
vibrations.
E, E, E,
Okay.
While auscultating, we ask the patient to breathe deeply and somewhat more than the normal. We listen to the breath sounds with the diaphragm of a stethoscope. We compare the systemic area of the lungs and note the vesicular breathing. And thus we conclude the examination of thorax and lungs.